Hello, today I'll be talking to you about a drug product called Neuro Oral Solution. So I'll be talking about the mode of action of cyclosporin A, annotated here as CSA. Cyclosporin A is an immunosuppressant and it works by binding onto an immunophilin called cyclophilin, which is usually found in T cells. So what you're looking at here, the diagram, is a T cell. This complex of cyclophilin and cyclosporin inhibits calcineurin. And calcineurin is responsible for activating the transcription of interleukin-2. And it does this by dephosphorylating nuclear factors so that active nuclear factor can increase the gene coding for IL-2. And so once you inhibit that, you don't get any gene coding. And so what do you get? You get a lowered activity of T cells and the immune response. So what exactly is cyclosporin A used for? So its number one indication is in organ transplantation. Neuro is used for the prophylaxis or delay of organ rejection in kidney, liver, and heart allogenic transplant. So when you use cyclosporin for this indication, you must use it within 12 hours before surgery and maintain as a daily dose for 1 to 2 weeks post-operatively before being gradually reduced to a maintenance dose, which is a dose you'll be on for the rest of your life as long as you have that organ in your body. So, route of administration for cyclosporin A. There are quite a few route of administration, which includes IV injection. So this one route is intravenous. That's injection there. There's eye drops for it. So the route would be ocular through the eye. That's the Restasis eye drop. And then there's also soft gelatin capsule. And so that's the capsule there. And the oral solution, which is the main focus of this PowerPoint. And both of these, the route of administration is oral. And so that is the oral liquid solution right there. Now we'll be talking about biopharmaceutical considerations to oral drug delivery. When talking about the biopharmaceutical considerations, you need to talk about the barriers that exist that may limit the delivery of the liquid drug orally. These barriers we discussed in relation to the physical properties, the pharmacokinetic properties, and the pharmaceutical considerations needed to overcome these barriers to enhance oral drug delivery. So when talking about barriers, we need to talk about the physical properties of the drug because it plays an important role in its absorption in the body and may prove to be a barrier for oral delivery. So cyclosporin A is a cyclic undecapeptide composed of a chain of 11 amino acids. It's a high lipophilic drug and it has poor solubility in gastrointestinal fluid. And there's the drug right there. And because of its lipophilic nature, a pharmacokinetic barrier would be its absorption in the gastrointestinal tract. So because it's lipophilic, it's for absorption when administered orally. The absorption in the gut is slow, incomplete, and highly variable between patients. The main site of absorption is the upper part of the small intestine, and hence rate and degree of absorption is highly subjected to physiological factors such as gastric emptying, bile flow, and fatty food. So I'll start off with talking about gastric. So it's been shown that using an experiment that when taken with metoclopramide, so metoclopramide has a tendency to increase gastric emptying, you can see the cyclosporin bioavailability was decreased, and vice versa. So you have a decreased bioavailability of cyclosporin. It was also shown that diarrhea greatly reduced absorption of the drug, and so this is a very important clinical consideration for patients, special patients groups such as those with abnormal gastric. Bioflow also becomes a barrier because it's important for drug to mix with aqueous phase at the absorptive surface. This can be seen in liver transplant patients where poor oral absorption of cyclosporin is associated with external bile drainage, and this was dramatically improved when the T-tube is clamped, with levels of cyclosporin raising by a factor of 5. So efflux pump pump is also another barrier. Cyclosporin A can be seen to passively diffuse through the intestinal barrier, and its transport can be seen to be affected by efflux pumps such as P glycoprotein. So it's a P glycoprotein substrate. So this results in the decreased bioavailability of the drug when taken orally, because what the P glycoprotein does is it actively kicks the drug out. And so not just that, but the concentration of cyclosporin itself is also affected by other drugs if taken at the same time, such as inducers or inhibitors of PGP. Another pharmacokinetic barrier that cyclosporin A face is metabolism. Cyclosporin A is extensively metabolized in the liver, with as much as 50% of the newly absorbed oral dose being extracted during its first cycle to the liver, which is called the first pass effect. The main enzyme involved in cyclosporin metabolism is cytochrome P450-3A enzyme. Although most of the cytochrome P450 enzyme is in the liver, there are a few in lesser amounts found in the kidney and the mucosa of the intestine. So this gives rise to another barrier, as it will suggest that metabolism within the intestinal cell wall is also an attribute to cyclosporin's very limited oral bioavailability. And so as a result of poor absorption and perhaps first-pass metabolism, a barrier it exhibits is poor and highly variable bioavailability, with only 30% of the drug reaching the systemic circulation when orally administered. So these are all the barriers that need to be put into consideration when designing cyclosporin. So now I'll be talking about the formulation of the neuro-oral liquid solution. Although cyclosporin A is formulated to a variety of dosage forms, liquid dosing form is very crucial and preferred in many scenarios due to the property of its formulation. And here I'll compare the liquid formulation to a few other type of formulation. So firstly, the comparison between liquid formulation and capsule formulation. So I'll start off with the advantages of liquid formulation. So firstly, liquid is easier to swallow compared to capsule, and this is very good for like pediatric or geriatric patients and any other patients who can't swallow properly. However, capsule formulation has many advantages. It's very convenient. There's no mixing or measuring of medication. It is very portable, easy to carry around. It's easier to carry like a few tablets around than a whole bottle of solution. There's no oily taste associated with the capsule like it is there with liquid formulation. And accuracy is ensured, so there's no risk of inaccurate measurement. And so this is very good for patients who have difficulty measuring medication out, who might be visually impaired, and so they can always get an accurate dose. So when comparing liquid formulation and injection, liquid formulation has a few advantages over injection. So the first one is obvious, where it does not require administration by health professionals. You can just take the liquid at home. And so that means that you're not confined to a hospital environment. So this is very suitable for most patients who are on cyclosporin, who are on long-term maintenance dose and need to take it home and who can't always stay at the hospital. However, with injections, an advantage is that they are ideal for drugs with poor oral solubility, such as cyclosporin, because of its immediate release to the bloodstream, and also because it bypasses first pass metabolism. Now I'll be talking about neuroformulation not just as an oral liquid formulation, but also as a self-microemulsifying drug delivery system, also known as SMEDS. So it was formulated as SMEDS to counter cyclosporin A's physicochemical properties of being highly lipophilic and therefore very low in bioavailability when taken orally. The aims of this formulation was to rapidly release cyclosporin A into the gastrointestinal tract without it precipitating out of solution when diluted in aqueous fluid. It also needs to be in either drinking solution form or a capsule to increase patient compliance, and also be able to deliver a high dose of the drug with the least amount of excipients, and not be able to be easily altered by the physiological state of GIT, as I mentioned before, such as bile flow or gut. So this is just a diagram of the SMED system and how it helps with transportation of the drug. So this helps drug absorption through a variety of different ways. The first way is increasing the membrane fluidity, which facilitates transcellular absorption. The next one is inhibition of PGP or CYP450 to increase intracellular concentration. The next one is opening the tight junction to allow paracellular transport, and the last one is stimulation of lipoprotein production so that it aids in the absorption of the drug. The clinical performance of SMED was incredible. It showed greater bioavailability with an increase of up to 239% compared to the old formulation. The time to reach maximum concentration was within 1.5 to 3 hours after oral administration. Hence, you have a more predictable and extensive drug absorption, which allows the doctors to predict the exposure of Cyclosporin A in the body and reducing the need for regular blood monitoring. Now to the stability of Cyclosporin A. Cyclosporin A, because it is taken orally, needs to be stable under acidic environment that is the same as the stomach. So when tested at 37 degrees and under pH of 1.1 and 3.0, the half-lives were 63 and 79 hours respectively. As a dry powder with no formulation, it is stable for over 7 months at 40 degrees and under 75% relative humidity. The SMEDS formulation, which contains 10% cyclosporin, can be stable for several years, and the stability itself is not affected by acidic conditions or in blood or in fat emulsion. However, because it is an emulsion, it has the potential to crack, cream, or phase invert if not stored properly. Storage. So these are just some of the storage requirements that the manufacturers have given us. So now we're on to excipients of neural. So other excipients. So the active ingredients is 100 gram per 1 ml of cyclosporin A, and it is dissolved in ethanol, which is a water-miscible non-aqueous solvent. Other inactive ingredients that play a very important in this formulation of this microemulsion are corn oil monoditriglycerides, which is a fatty vehicle or a solvent, propylene glycol, which is an antimicrobial preservative, but it can also act as a humectant, plasticizer, solvent, and a co-solvent. The DL-alpha tocopherol, which is a highly lipophilic compound used as solvent for many polysoluble drugs such as Cyclosporin, and chromophore, which acts as a hydrophilic surfactant is obtained from reactions between polyethylene and vegetable oils. So this ingredient right here is also said to inhibit P-glycoprotein, which, like I mentioned before, helps the absorption of cyclosporin. So in conclusion, this PowerPoint has talked about the importance of drug physicochemical properties, its pharmacokinetics, as in what the body does to the drug, and the necessary considerations, the biopharmaceutical considerations needed when overcoming these properties of pharmacokinetics. We also talked about the importance of liquid formulation and how it is better than some other formulations in some instances. And to end it off, I just want to say that Cyclosporin A was the first drug to be formulated using SMEDS, and the incredible improvement in the bioavailability of the drug highlight how important it is to have biopharmaceutical considerations when designing a drug. Thank you.